the different perspectives merge together and will result in something that's fantastic. David, may we ask you to summarize a few issues?
So I was going to make slides, but it sort of defeats the purpose a little bit because we haven't had a chance to discuss things. And I think the 20 minutes we've got, 25 minutes we've got is better spent discussing things. There are a few themes that emerge. We started off by looking at data from the big interverse studies, and we're looking for cross-connections, for similarities, for discordances between them as a means of understanding both the disease and how we should treat it. That's the first theme. The second theme is, we had a little bit of discussion about this. It's a shame that Franco's gone because we could make it really lively now, was what we do about the guidelines we provide to people. To my mind, the question isn't about whether people believe in guidelines or not. The issue is that I think there's a discordance between people who say that all of the guidelines should be evidence-based to those who say that some guidelines which support clinical care is better than none. So the second issue is the guidelines. And the third issue, which ties to both of those, the research and how we practice clinical care, is the issue of global health. So Matthew Joseph, who came for the global health meeting in Cambridge, told a story which really has stuck in my brain. We were talking about rapid transport to hospitals, and he said about this young man who had had a head injury, PCS of under 8, comatose, and brought really rapidly to the hospital by his friends. They didn't have an ambulance, so they strapped him onto a motorcycle. His friend rode the motorcycle, and he came along behind, strapped on. He got there within 17 minutes after the head injury. The problem was they hadn't realized that because he was comatose, his feet were dragging on the ground. By the time he got there, he had bilateral forefoot amputation. So this is multiple trauma caused by transport as opposed to everything else. So we really need to understand the problems and issues. What I would like to do is, rather than me talking anymore, is to address those three things, but in reverse order, starting with global neurotrauma, and how we make this relevant to the 80 to 90% of people that we haven't produced enough data for. I'll start off by saying that this morning we had a really good discussion about having a global neurotrauma registry where we get the minimum amount of data from as wide a population as possible, and then more data in a stratified manner from smaller and smaller numbers of units. So let's start off. Any thoughts about global neurotrauma? How do we make this relevant? And for a change, I'd like to ask non-LMIC partners to reflect on what they think about what we've heard today. Stunned silence at the back.
I think the challenge is going to be getting data in the low middle income country setting, and I just wanted to say that there are trauma registries already out there in low middle income countries. So I was listening to Tariq's presentation, and Tariq, I wondered if you knew about the Pan-Asian Trauma Outcome Study. That does include hospitals in Pakistan. So some of the existing low middle income trauma registries will have some TBI data that could be harnessed for a global neurotrauma initiative.
So that's useful, because the point that Key made earlier, and I'll ask you to amplify on that, is we talked about getting really good data from a small number, maybe from neurosurgeons, slightly wider data from anyone who's medical and sees patients with TBI, and then a broader interaction with the registries and public health people. Do you want to just say a few words about that?
So what I've noticed when we gather as surgeons, I mean, you're obviously you're not a surgeon, but we tend to default to the typical way we think and do things, which is very narrow scoped. And what we're dealing here with is a global public health issue. It's affecting millions of people. And in order for us to move the needle, we have to talk and think like global public health people. These are funders, these are policymakers. So I think it's important, while we're talking about this, to always have this one foot or one eye towards this, what would be the meaningful information that will help drive things forward. So these are things like burden of diseases, these are things like income disparities, financial risk protection for different levels of the society. So I think if we start to at least move a little bit from the technical part of the neurosurgical care to some of the social aspects, I think they'll be very meaningful.
So at the first meeting we had when we were setting up INTBEAR, Graham Teasdale, as with many things, Graham thinks of things in neurotrauma before everyone else does. He made the point that it may be much less important as to what operation you do rather than what health system you do that operation in for someone with traumatic brain injury. So I think the systems of care is important. Tony made another really important point, and you're not really LMIC, you're upper MIC, so I'll let you talk. Do you want to say the point you made about advocacy?
Yeah, so we had the discussion this morning, and the point that I made, certainly for Africa, and one sees it in different forms in other low and middle income countries, there's a disproportionate amount of funding that goes to infectious diseases, and we suffer because of it. Infectious diseases are, of course, is incredibly important in a South African, at least an African context. But if you look at the amount of funding that goes to it, it's the lion's share. Probably to about 80 to 90% of funding that comes outside of Africa for conditions in Africa goes to infectious diseases. And it's far disproportionate to the actual burden of disease. So if you look at my neck of the woods, neurotrauma accounts for a similar amount of years of potential life lost, but in terms of funding for clinical care and funding for research, it's the small minimum minority of funding that it gets, and I don't understand why it is. In part, it's because I think the advocacy group, especially for HIV/AIDS, have been so incredibly successful over the last two decades, and I think we can learn from that. I think we can also learn from kind of neurologists and advocate also to Lancet Neurology and other kind of large bodies that this is a neurological disease, and it's the biggest killer of neurological diseases for young people. But somehow the reality of the burden of disease, we're missing it. Maybe it's because it's mostly surgeons that are advocating, and we're not really good at this, so we need public health professionals to help us. But we've got all the materials, and people have done a lot more with a lot less. And somehow we need to get some advice about advocacy, because I think that's clearly where we're going to benefit.
So one of the things that we would probably, I just got told off by Vero because I was standing in front of the camera and they was looking into my bald head at the back, which is a bad idea. So one of the things we said is the case that we need to put together is to go to Bill Gates and say, look, this is a killer. Are you going to put your money where your mouth is? So that's what we need to do by 2020. Where's Elena? She's Andras and then back.
So basically, as Franco referred to by Bulgaria and Romania, in the early 90s we were in the same situation in Hungary. So probably I can share some of our experience. Basically, the major issue is to have hard data on hand. So I think that you cannot basically go to policymakers without having those data. And I think that from this aspect, the INBIR and the global initiative is a major issue. And every country and devoted people should join this initiative. This is the first thing. The second thing is that you have to use the data, which is the more difficult issue. Because I would love to say that we changed the game in Hungary, but we did not. We have a high-income country with a healthcare system acting as a low or middle-income country's healthcare system. But still, we hope we are in a good good path, and actually, CENTER-TBI helps a lot, and these events helps a lot, and probably this also interconnects to the guideline issue. But having the data on hand, you have to have the international guidelines, take the guidelines and try to adopt to your country's actual need. That's what we did with the 4th edition, making it a practical guideline as well, but evidence-based one. There again comes a trap, because if you go too much down with the expectations and you adopt it to the actual situation, policymakers will be happy and leave everything untouched. But if you set the bar too high, then they will not give you the money for the resources. So it's a really touchy issue. And I think that the WFNS started a very good approach, and I hope that the ENS will also join it. So I think with the aid of the data from Center and the INBIR, this is the way.
I think we should approach Bill and Melinda Gates, but I think we have to understand the impact of some of the work of HIV, AIDS and TB in Africa. So it's my understanding that some of the HIV treatment systems in West Africa have set up entirely new healthcare systems to deliver those drugs because they had absolutely no faith in the local healthcare systems. It's not going to be possible for us to set up whole new emergency care systems in these countries. So I think we need to think really creatively about how we engage these funders to get a result.
I hate it when my dreams are shattered by reality. There we go. Okay, so the next question, I suppose, is going back to the guidelines issue. There are two options. One is to have guidelines that are actually less and less demanding, and this is the point that Andras was making. But here's a thought, and it would be interesting to see what you people think about it. Rather than call these guidelines for low and middle income countries versus high income countries, why don't we call them guidelines for resource-limited environments and non-resource limited environments? With resource-limited environments, even if you're a US task force working in the Atlantic somewhere and you don't have the resources available, or you're out in the field somewhere and you don't have the resources available, then you may need to resort to some of the paradigms of care, not necessarily the technology of care, but the paradigms of care that allow you to get away with less technology. I thought this was right, but I heard someone from the Department of Defense speaking in Washington a week ago when Andrew, myself, and the rest of the Interberg population were there, where they want to take biomarkers out to the field. They see that as a viable tool. Now, are we right in trying to find resource limitation as the division between these two sets of guidelines? Or should we say, look, it's fine to say this is for low and middle income countries, the resources are limited, and we have to recognize the context has to do with the economy. What do people think about that?
So basically what the Neurotrauma Committee of the WFNS did in our last meeting, and it was there as well, was that there was this trap where we said that if we put the goals too low, the governments would be very happy and say, well, that's fine, you know, you have that resource and you carry on with that. So we decided, and we made a small committee to make multi-level guidelines where you have a, you know, and so you can show to people that, no, that is the gold standard. Here's how we have to go, but in this present situation, this is what we can do. And we hope that in this year or so, we'll have developed those guidelines. I think that would be very important, whatever you want to call it, resource limited or not. But like you have to show to the governments that this is not it. Like there are many levels, and you have to go to the top, but presently you can do with this. That's how we are trying to do it. So, so we have got Andres Rubiani from Colombia. He's heading this little committee. And they're looking at different people and talking to them and seeing how they can develop that.
No. Okay. So we've got just 5 minutes more. We don't have to go to the end of the discussion period. But is there anything else people want to bring up that they think is important, interesting, want to get it off their chest? No? If not, then I think we should probably stop. The wine will be outside. I'll hand over to Andrew to say the last few words. Then, you know.
I think I need to keep you busy for another few minutes. David's cognitive functions are suffering a little bit in the course of the day, perhaps. To be serious, this has been a fantastic day. I didn't really know in advance what to expect of it. I had, in a way, a little bit of mixed feelings. We'd worked so hard on the commissioned issue, and here it was being launched, and of course our expectations were too high initially. We thought of a launch in a big session at the European Parliament with maybe 10–20% of the parliamentarians present and a really big occasion. And we ended up in a very nice room, but small, for 40 people. And there was less than 10% of the audience were parliamentarians. So we didn't really reach the target audience which we'd hoped for. But nevertheless, it was an excellent session, and to my great joy and surprise, it was evident that the MEP who had facilitated it, in her opening speech, she hit exactly the targets we'd mentioned in the commission. How she had extracted them, I don't know, or her co-workers, but it was right on target. So the good message there is, yes, we have managed to reach the political level and present things in a way that they extract the information which is necessary. We have additionally, and that was only just ready yesterday evening, come up with an infogram. Everyone I told to from media across the world, they said, this flyer you have with some information, it's wonderful, it's beautiful, but there's no politician who will ever read it. There's no press officer who will ever read it. Their attention span is maximum 3 or 4 lines and then it's gone. So you need bullet points. Preferably, you need some stupid cartoons called an infogram, and that is effective. So we did that, and the small company we did it with, a small Dutch company, managed to do that within a week, with help from the editors of the Lancet Neurology. And I think that'll be pretty successful also. The Lancet Neurology itself, you have the commissioned issue. If you want more copies, because they're all gone now, like cookies, they're all gone. If you want more, and I can well imagine many of you want more for your department, let us know. And they have promised us that they will be delivering them. This commissioned issue will also form part of the regular December issue of the Lancet Neurology. And in that regular December issue, there will also be a 2-page story on CENTER-TBI, written by one of the medical writers of the Lancet Neurology, who some of us have excellent experiences with and some of us slightly less good experiences, but there may be an occasion to discuss that. This production has truly been a team effort, and David and I are extremely grateful to all of you for having participated in that. Everyone is equal. But some people are a little bit more equal than others. And there are 2 people in the audience who we would like to especially thank. One for putting us into hell and through hell, and the other for getting us out of hell all too often. The first for putting us into hell was Alison. You've done fantastic work. Alison is senior editor of the Lancet Neurology, and she has really done a fantastic job. We wanted to address that in the acknowledgements in the Lancet Commission, and the higher editors, they said, no, we can't do that. That's not Lancet policy. We can't do that. I said, well, we sometimes do things which we shouldn't be doing, and we do it. They said, no, we can't. So this is just a small token of our gratitude, Alison. Thanks a lot. The other person who saved us from hell all too frequently is Vero, sitting in the back.